Hey, I'm Joseph Delaney. I'm a pediatrician at SouthernMED Pediatrics. Yes, I think if you're concerned about potential exposure, or if you know for certain that you've had exposure and you're confused about the recommendations for quarantine or the recommendations for testing, because it is an ever-moving and somewhat confusing area, I think, by all means, give us a call, have one of our staff, our nurses, or one of our providers talk you through when the recommendation is and what isolation or quarantine looks like, and if we recommend testing, at what point we'd like to do that. There's a difference in direct contact with an individual who's positive versus indirect contact. So if you have a child in the classroom who you receive notification that they have had a direct exposure, they're considered a direct contact. If they are asymptomatic, then family members at home are considered an indirect contact, and you do not, as an indirect contact, have to fulfill all of the quarantine and isolation guidelines that DHEC and CDC give. If that child who, in the same situation, becomes symptomatic, then there will be some consideration for testing and what does that mean for mom and dad and caregivers at home now that that person who we know had contact has symptoms. Then they become more of a concern for them being a direct contact as well. CDC and DHEC did recently revise their protocols, and the protocols changed from the required 14-day quarantine to a recommended 14-day quarantine. They still say that is best practice, but they have allowed for some carve-outs to say that you could do 10 days post-exposure if you have no symptoms during the 10 days, and you can even shorten that further to 7 days post-exposure if you had no symptoms during that 7 days and you have a negative test that was collected during that 7-day period of time. So currently we're recommending if they have symptoms at all, particularly fever and respiratory symptoms, but also including things like sore throat, headache, body aches, chills. We have also seen some patients complaining of symptoms like diarrhea, nausea, and vomiting as well. It seems like the symptoms throughout the pandemic have broadened as we've learned more about the virus. But certainly would recommend with symptoms, with known exposure, particularly household exposure or known direct contact. We think those kids need to be tested as well to help parents know about activities and school and what to do as far as like their work and things like that. There is a difference. So a send-out is typically a PCR-based test. PCR testing is what's considered by experts to be the gold standard. And by that, it's supposed to give you less likelihood of false negatives and or false positives. What we've learned is that no test is perfect, but when you look at the guidelines that are being provided to us, PCR is sort of the recommended gold standard. The in-house testing, it currently for us is not a PCR platform. It is a rapid antigen test, which when they compare it head-to-head to PCR is, as far as the sensitivity goes, it's about 96 to 97% sensitive and about, well, they recommend like 99 to 100% specific. So it gets pretty close to PCR, but there is a subtle difference and maybe not quite as good as what you get from a PCR result. So oftentimes when we're recommending testing to patients, we're looking at all of those factors. So I've got to look at what I've got, in my lab at my disposal, because it may be that I don't have the option for the rapid because we just don't have it in stock. If we've got it in-house, then we have to look at the turnaround time and what that means for that particular child and that family. Are they a child who's not in daycare and doesn't have a need to get back to school, and so the additional 24 to 72 hours isn't that imperative for that family, so we may send the PCR out in that situation. If it's a kid that is in school and we really want them not to miss any more school than possible, then if we've got an antigen rapid test at our disposal, we may use it in that scenario. There is some conversation with the usefulness of the rapid test in an asymptomatic contact, and it's not the best test if a child is completely asymptomatic but has a known exposure. In that scenario, most of the time we're going to recommend a PCR test. So, another important thing to think about, certainly for our high school athletes and even collegiate athletes, is if you have an athlete who tests positive for the coronavirus, then there is some consideration for them having additional screening when they're through with their illness and they're feeling well. There's consideration for additional screening to rule out any cardiac damage from the virus before they return back to activity. There are some stipulations or recommendations out there, and we would be glad to walk you through that if you have an athlete who does test positive, whether it's from our office or whether it's from an urgent care ER. There are considerations that we would maybe need to assist you with to get that additional workup done. I think it has to be kind of case by case. It's weighing the risk of getting the disease or potentially spreading it to your loved ones and your contacts versus the risks of what the vaccine has itself. I am hopeful and really believe that our science is where it is in 2020 in this state, of science and technology, that we're not new to vaccines. We've been making vaccines for a long, long time, and there's nothing crazy new with what they've done with these vaccines, to my understanding. So if you look at lots of years of research and lots of knowledge in science backing vaccines in general, I feel that the safety should be, it should be there. And I plan on getting it myself as soon as it's an option.